Good morning, everyone, and thank you for being here today. My name is Dr. Asim Hussein, and I'm excited to present to you on a critically important topic. Today's presentation is titled, Can't Intubate, Can't Oxygenate, or CICO for short. We'll be exploring the challenges, management strategies, and key considerations for this life-threatening situation. Over the next few minutes, I'll guide you through what you need to know to recognize and respond effectively. Let's get started. Now, let's look at the scenario here. We have a 62-year-old man who is obese and undergoing emergency rapid sequence induction in the ICU. Unfortunately, 2 attempts at laryngoscopy have failed, and despite using airway adjuncts, bag mask ventilation remains ineffective. His oxygen saturation has dropped significantly to 78%, even though he's on 100% oxygen, and a supraglottic airway also hasn't been successful. This situation highlights a critical point. When initial airway management fails and oxygenation deteriorates, we need to consider the most appropriate next step carefully. The options here include attempting another video laryngoscopy, increasing FiO2 and continuing bagging, declaring a can't intubate, can't ventilate situation, and proceeding to emergency front-of-neck access, inserting a nasopharyngeal airway, or waiting for ENT specialists to arrive. The key concept is recognizing that this is a life-threatening airway emergency. The priority is to secure the airway rapidly to restore oxygenation. Repeating attempts without success may delay definitive action. Increasing FiO2 and continuing bagging might help temporarily, but given the failure of initial efforts and ongoing desaturation, we need a more decisive step. Declaring a CICO, meaning the patient can't be intubated or ventilated, is crucial here. It alerts us to the emergency nature of the situation and prompts immediate action, specifically, proceeding to emergency front-of-neck access to establish a definitive airway. While inserting a nasopharyngeal airway or waiting for ENT specialists might be useful in less urgent situations, in this scenario, the rapid deterioration signals that we must act swiftly. So, the most appropriate next step in this critical moment is to declare CICO and move directly to emergency front-of-neck access. This approach maximizes our chances of re-establishing oxygenation and preventing a catastrophic outcome. Let's look at the correct answer here, which is C now. The key point to understand is that CICO stands for can't intubate, can't oxygenate. This situation occurs when, despite our best efforts and optimized attempts at intubation, we are unable to secure the airway or provide adequate oxygenation. Failure of both intubation and oxygenation is what defines CICO. It's a critical and potentially life-threatening scenario that demands immediate action. In such cases, waiting or hesitation can be disastrous. The most important takeaway is that immediate front-of-neck access, also known as surgical airway, becomes life-saving at this point. It's a last resort, but in CICO situations, it's often the only way to restore oxygen flow and save the patient's life. So remember, quick recognition and prompt action are essential, because delays can lead to severe hypoxia and irreversible brain injury. This slide underscores the importance of being prepared to act swiftly when faced with failure to intubate and oxygenate. When faced with a patient in the ICU who's declared CICO, meaning cannot intubate, cannot oxygenate, after multiple failed attempts at securing the airway, we need to act quickly and decisively. In this scenario, traditional methods like reattempting laryngoscopy with a different blade or trying supraglottic devices have already failed, and bag mask ventilation isn't maintaining oxygenation. At this critical point, our priority is establishing a definitive airway rapidly to prevent hypoxic injury. The options we consider include needle cricothyroidotomy with jet ventilation, scalpel, bougie cricothyroidotomy, emergency tracheostomy, and high-flow nasal oxygen. While high-flow nasal oxygen can buy some time, it's not definitive in a can't intubate, can't oxygenate situation. The most effective and immediate definitive airway management in this context is scalpel, bougie cricothyroidotomy. It's considered the gold standard because it provides a quick, reliable airway through a surgical incision directly into the trachea, allowing us to secure oxygenation and ventilation at the source. Understanding this decision is crucial because, in emergencies like this, the right choice can be life-saving. It exemplifies the importance of being prepared to perform surgical airway access when all other methods have failed, and highlights the significance of having a clear algorithm to guide us in these high-stakes situations. The correct answer here is C when it comes to adults. The scalpel bougie cricothyroidotomy is considered the fastest and most reliable definitive airway in cases of CICO, which stands for can't intubate, can't oxygenate. This method is preferred because it allows for quick access to the airway in urgent situations, minimizing delays. It's important to understand that in emergency airway management, speed and reliability are crucial, and the scalpel bougie technique has proven to be effective in these high-stakes scenarios. This ties into our overall theme of emergency airway protocols, emphasizing that knowing the most efficient technique can really make a difference in patient outcomes. Now, let's look at this question about emergency airway management. When oxygen saturation drops while multiple airway techniques are attempted without success, it's crucial to identify what most often leads to adverse outcomes in these CICO situations. The options here include the use of neuromuscular blockade, delayed declaration of CICO with repeated attempts, inadequate pre-oxygenation, use of video laryngoscopy, and use of supraglottic airway devices. What stands out as the most common contributing factor to patient demise in these critical moments? It's actually often the delayed recognition and declaration of CICO, combined with repeated attempts at airway management. This delay can lead to critical hypoxia, which is why timely decision-making and escalation are so vital. In other words, not declaring CICO early and persisting with multiple unsuccessful attempts can significantly reduce oxygen levels and increase the risk of severe outcomes. Recognizing when to escalate and switch to alternative airway strategies is key to improving patient survival. So, understanding this helps us appreciate the importance of prompt, decisive action and the need to move quickly to alternative airway devices or techniques when initial methods fail. This is a central theme in managing airway emergencies effectively. The correct answer here is B, and I want to emphasize that the most lethal mistake in a cricothyroidotomy, or CICO situation, is delay. What often happens is that clinicians might get caught up in repeated attempts to insert a tube or manage the airway non-surgically, when the reality is that time is of the essence. Instead of wasting valuable moments on multiple failed attempts, the key is to recognize when it's time to move directly to a surgical airway. This decision can be life-saving. So, the main takeaway is that hesitation or delay can be deadly, and knowing when to proceed with a surgical airway is crucial in managing these critical situations effectively. Now, let's consider the scenario where a scalpel bougie cricothyroidotomy has been performed in a CICO emergency, and we observe that the patient's oxygen saturation is starting to improve. The key question here is, what is the most reliable method to confirm that the tube is correctly placed? Looking at our options, we can eliminate some quickly. For example, chest X-ray, while useful in some settings, isn't the most immediate or reliable method in an emergency situation like this. Improvement in oxygen saturation is a good sign, but it doesn't tell us definitively that the tube is correctly positioned. Bilateral breath sounds are helpful, but they can sometimes be difficult to assess accurately, especially in an emergency or if there's any trauma or other complicating factors. Continuous waveform capnography, on the other hand, is considered the gold standard here. It provides real-time, objective confirmation of airway placement by detecting exhaled carbon dioxide. Tube fogging can also be suggestive, but isn't as reliable because fogging can sometimes occur even if the tube isn't in the trachea, especially in certain conditions. So, in this critical moment, the most reliable method to confirm correct tube placement is continuous waveform capnography. It offers immediate, definitive feedback, which is vital for patient safety. This ties into the overall theme of airway management, always confirming placement accurately and promptly to ensure effective ventilation. The correct answer here is D. Waveform capnography is considered the gold standard when it comes to confirming tracheal placement. What that means is, it provides us with real-time, reliable evidence that the tube is in the right position. Unlike other methods, waveform capnography gives us a clear, visual pattern of exhaled CO2, which is crucial for ensuring proper placement. This is especially important in emergency or critical situations where quick and accurate confirmation can make a real difference in patient safety. So, when we're verifying tube placement, waveform capnography is our most trusted tool, aligning perfectly with our overall goal of providing the safest airway management possible. When faced with a rapidly deteriorating ICU patient during intubation, especially with dropping oxygen levels and poor ventilation, it's crucial to act swiftly and effectively. In this scenario, the key is to recognize that continuing attempts without a clear plan can worsen the situation. Choosing to continue attempts until SpO2 drops below 70% might seem persistent, but it risks severe hypoxia. Administering reversal agents can be helpful if a drug-induced issue is suspected, but it's not the immediate best move. Calling ENT before acting could delay necessary intervention. The most effective action here is to make an early verbal declaration of CICO, that is, can't intubate, can't oxygenate, and assign roles clearly. This helps coordinate the team quickly and prevents confusion. Switching to awake fibroptic intubation is often the most definitive way to regain control of the airway under these critical conditions. It allows for airway access while maintaining spontaneous breathing, which is vital in a developing, cannot intubate, cannot oxygenate situation. Overall, the priority is to recognize the crisis early, communicate clearly, and switch tactics swiftly. That way, we maximize our chances of stabilizing the patient and preventing catastrophic outcomes. The correct answer here is C. Now, let's break down why that's the case. When managing a difficult airway, especially in emergency situations, early verbal declaration of CICO, that's can't intubate, can't oxygenate, is crucial. By clearly stating CICO early on, we trigger a rapid transition to front-of-neck access, such as cricothyroidotomy. This prompt action helps us avoid what could be a fatal delay. Essentially, the key takeaway is that recognizing and announcing CICO right away allows us to move swiftly to the definitive airway, which is life-saving. This step is vital to prevent hypoxic injury or even death, reinforcing the importance of preparedness and quick decision-making in airway emergencies. Today, we're focusing on a critical emergency situation. Can't intubate, can't oxygenate, or CICO for short. This is a rapid-fire emergency guide, meaning we need to act quickly and confidently. When standard intubation fails and oxygenation cannot be maintained, time is of the essence. The most important concept here is to recognize early when you're heading into CICO territory, so you can implement the emergency plan without delay. This slide emphasizes the need for preparedness and having a clear, step-by-step approach ready to go. The key points include understanding the signs that indicate intubation is not successful and oxygenation is dropping. Once identified, you need to move swiftly through the rescue steps, whether that's alternative airway techniques or surgical airway access. Overall, this slide ties into the bigger picture of airway management, reminding us that being prepared for the worst-case scenario can make all the difference in saving a patient's life. The goal is always to maintain oxygenation and prevent hypoxic injury, even in the most challenging situations. Let's take a closer look at the definition of CICO. CICO stands for failure to intubate plus failure to oxygenate despite optimal attempts. Essentially, it means that even when we try our best to secure the airway through intubation, we're still unable to ventilate the patient effectively. This situation is critical because you might see the SpO2, or oxygen saturation, drop below 90%, which indicates significant hypoxia. When bag mask ventilation becomes ineffective and supraglottic airways also fail or are impossible to place, we're faced with a life-threatening emergency. It's important to understand that this scenario is time-critical. Minutes can make the difference between life and death. Because of the rapid deterioration, recognizing CICO early and acting swiftly is absolutely essential. This is why the phrase, "can't intubate, can't oxygenate," really captures the urgency of this situation, emphasizing how quickly things can escalate if we don't intervene promptly. Let's talk about some critical red flags that you absolutely cannot delay addressing. First, if you notice rapid desaturation despite giving 100% oxygen, that's a major warning sign. It indicates that oxygen isn't effectively reaching the lungs or being exchanged. Next, an impossible bag mask ventilation, or BMV, which we often see as poor chest rise, tells us that the airway isn't being adequately managed. If inserting a supraglottic airway, like an SGA, fails, that's another red flag, meaning we're struggling to establish a secure airway. A silent chest, where there's no breath sounds or chest movement, is extremely concerning. It's a sign of severe airway compromise or apnea. Cyanosis, or a bluish discoloration, indicates low oxygen levels, and we need to act fast. Bradycardia, especially if it progresses toward cardiac arrest, is a critical sign that the patient's condition is deteriorating rapidly. Now, a very important point. Repeated attempts at airway management can actually cause more harm than good. Each attempt risks trauma or swelling that can worsen the situation. Remember, if we reach a point where we can't intubate and can't oxygenate, that's the CICO scenario. It's a dire emergency, and having a clear plan for this situation is essential. Recognize these signs early, act swiftly, and know when to escalate or switch strategies. All right, let's walk through the failed airway cascade, or the exam sequence, and what happens when initial attempts don't succeed. First, if direct or video laryngoscopy fails to visualize or place the tube, that's our first big hurdle. Next, even when we optimize bag mask ventilation, sometimes it still doesn't work effectively. Then, if supraglottic airway devices also fail to establish a secure airway, we reach a critical point. That's when we declare CICO, can't intubate, can't oxygenate. At this stage, it's crucial to move on quickly because time is of the essence. This sequence highlights the importance of recognizing failure early and being ready to escalate to alternative techniques or emergency procedures. Remember, the overall goal is to maintain oxygenation and prevent hypoxic injury, so knowing when to move on is key to successful airway management. This is CICO. Prepare for emergency front-of-neck access. First, call for help. It's crucial to get additional support on hand quickly. Next, allocate roles. Make sure someone is ready to assist or manage equipment while you focus on the procedure. Then, prepare the scalpel bougie kit. Having it ready and within reach can save valuable time. Remember, this is a can't intubate, can't oxygenate situation, a critical emergency. In these moments, rapid recognition and preparation are key. Always be ready to act decisively to secure the airway and ensure oxygenation. When it comes to definitive management, do not hesitate. If you find yourself in a situation where emergency front-of-neck access, or FONA, is needed, remember that the preferred method in adult ICU settings is scalpel, bougie cricothyroidotomy. This technique is reliable and should be performed without delay when indicated. Now, it's crucial to avoid certain pitfalls. Repeated laryngoscopy can cause trauma and delay securing the airway. Needle cricothyroidotomy alone is generally not recommended because it has a high failure rate, especially in emergency scenarios. Waiting for senior help or more advanced procedures can waste precious time, and in critical moments, hesitation can be deadly. This all ties back to the overarching theme of being confident and decisive in airway management. When faced with a can't intubate, can't oxygenate situation, swift action with the right technique is vital to save lives. All right, let's walk through the steps of the scalpel, bougie tube technique, which is a favorite in MRCP scenarios. First, we need to identify the cricothyroid membrane, which is the key landmark for this procedure. Once we've located it, we'll make a vertical skin incision to access the membrane safely. Next, we'll do a horizontal stab into the membrane itself, creating an entry point. Then, we insert the bougie through this opening. This acts as a guide for the tube. After that, we railroad a 6-cuffed endotracheal tube over the bougie into the trachea. Once in place, inflate the cuff and confirm placement with capnography, ensuring proper ventilation. The entire process should ideally be completed in less than 60 seconds. Remember, in a CICO situation, when we can't intubate or oxygenate, this technique is a critical rescue step. Staying calm, quick, and precise is essential for success. Now, let's talk about how we confirm that we've successfully secured the airway. One of the key indicators is capnography, specifically ETCO2 readings. A good ETCO2 reading confirms that air is passing through the lungs and that ventilation is effective. Next, observing chest rise is a simple but crucial sign. If the chest is rising symmetrically with each breath, it's a strong indication that the endotracheal tube is in the right place and the patient is being ventilated properly. Additionally, improving SpO2 levels provide reassurance that oxygen delivery is happening effectively. When these signs are present together, good capnography, chest rise, and rising oxygen saturation, it's a clear confirmation that our airway management has been successful. However, we must also be prepared for the worst-case scenario. The can't intubate, can't oxygenate situation, often called CICO. This is a critical emergency where traditional methods fail, and immediate action is required to secure the airway through alternative techniques or surgical airway access. All these points highlight that confirming success isn't just about one sign. It's about a combination of indicators that tell us we've done it right and are ensuring the patient's oxygenation and ventilation. And of course, staying vigilant for signs of failure helps us respond quickly and effectively. Let's take a closer look at some of the common causes of CICO in the ICU setting. First, severe airway edema is a significant factor, often resulting from trauma, allergic reactions, or infections. This swelling can quickly obstruct the airway, making ventilation extremely difficult. Next, anaphylaxis and angioedema are critical to recognize because they can cause rapid airway swelling and compromise breathing. These are emergencies that require immediate intervention. Obesity is another important factor. Excess tissue around the neck and airway can make both intubation and ventilation more challenging. Similarly, cervical spine immobilization, often necessary after trauma, can limit neck movement, complicating airway access and management. Trauma and burns are also prevalent causes, as they can lead to airway swelling, bleeding, or structural damage that obstructs airflow. An upper airway obstruction might be caused by foreign bodies, tumors, or swelling, all of which can suddenly block oxygen delivery. Failed rapid sequence intubation is a known scenario where initial attempts to secure the airway don't succeed, increasing the risk of deterioration. And finally, the most critical and feared situation is the can't intubate, can't oxygenate scenario, CICO, where despite our efforts, we cannot establish or maintain an airway, necessitating emergent surgical intervention. Understanding these causes helps us anticipate potential challenges and plan our approach accordingly to prevent catastrophic outcomes. Let's take a closer look at some common fatal errors or exam traps that can occur during airway management. First, attempting too many laryngoscopy attempts is a critical mistake. Each additional try can cause swelling, trauma, and make subsequent attempts more difficult. It's important to recognize when enough is enough and to move on to other strategies promptly. Next, delaying the declaration of CICO, or can't intubate, can't oxygenate, is another major trap. If we wait too long to recognize the situation and declare CICO, we risk losing valuable time and worsening the patient's condition. Early recognition and decisive action are key. Relying solely on SpO2 readings can also be misleading. While oxygen saturation is a helpful parameter, it can sometimes stay deceptively normal for a while, even as the airway becomes compromised. We need to assess the overall clinical picture, not just the numbers. Waiting for ENT specialists to arrive can be another trap. While consultation is important, delays in definitive airway management can be deadly. We must be prepared to act ourselves if necessary, rather than waiting passively. Hesitation to cut or perform an emergency surgical airway is also a critical error. Sometimes, it's necessary to make that decision quickly to save the patient's life, even if it feels uncomfortable or risky. Recognizing when to move to an emergency surgical airway is a vital skill. Finally, the most severe scenario, can't intubate, can't oxygenate, is the ultimate exam trap. It underscores the importance of early recognition, preparedness, and knowing when to escalate quickly. Being familiar with the entire airway algorithm helps us avoid these pitfalls and ensures we act decisively when it matters most. Let's go over some ICU PEARLS that are crucial in emergency airway management. First, when you see CICO, remember it stands for can't intubate, can't oxygenate, and it's important to understand that this situation calls for a surgical airway, not just oxygen therapy. This is a key point because oxygen therapy alone won't solve the problem in these critical moments. Next, front-of-neck access, like cricothyroidotomy, can truly save lives in these scenarios. It's a rapid, life-saving procedure that should be performed promptly when indicated. Also, declare early and act fast. The longer we delay, the worse the patient's chances become. Recognizing CICO early allows us to intervene sooner rather than later. Practiced skill is more valuable than just knowing the theory. These procedures are time-sensitive, and muscle memory can make the difference between life and death. It's also important to remember that needle cricothyroidotomy is not always the definitive airway. It's often a temporary measure, so be prepared to secure a more definitive airway afterward. And finally, when we talk about CICO, it's a reminder that we might face situations where intubation and oxygenation both fail. Being prepared, practicing these techniques regularly, and understanding the limitations of certain procedures are essential in these critical moments. All right, let's look at this one-line memory aid. No air in, no air out, cut the neck. This simple phrase is really a quick reminder for a critical situation known as can't intubate, can't oxygenate, or CICO. When you find yourself unable to secure the airway through intubation and oxygenation becomes impossible, it's a life-threatening emergency. The key point here is that if all else fails, no air is getting in and no air is going out. The definitive solution is to establish a surgical airway by cutting the neck. It's a stark but essential concept to remember because in such dire circumstances, quick action is crucial to save the patient's life. This memory aid helps us focus on the most effective and immediate intervention when conventional methods fail, connecting directly to the overall theme of airway management and emergency preparedness. Let's review the take-home pearls for CICO, which stands for can't intubate, can't oxygenate. First, remember that CICO involves both intubation failure and oxygenation failure. It's critical to declare this situation early. Don't wait too long, because prompt action can make all the difference. In adults, a definitive airway can often be secured with a scalpel, bougie cricothyroidotomy, so knowing that technique is essential. Repeated attempts at intubation or airway management can actually cause more harm than good, so recognize when it's time to move on. Capnography is our confirmation tool. It's how we verify success when establishing an airway. And always keep in mind that waiting for help in a CICO situation can lead to airway loss, which tragically could result in death. So, in summary, when faced with a can't intubate, can't oxygenate scenario, act quickly, use the right techniques, confirm success with capnography, and remember, delays are dangerous. Thank you for your time and attention today. I really appreciate you being here and engaging with the content we've discussed. Remember, the key takeaways are about how these insights can help you improve your strategies and achieve better results. I hope this presentation has been both informative and inspiring, encouraging you to apply what you've learned in your own work. Once again, thank you for your participation, and I look forward to seeing how you implement these ideas moving forward.